Yeah, I actually changed my title, as you can see here, without authorization, but I'll blame Dr. Systrom. He wants me to talk a little bit about things that might be more relevant to patients, although I'm a computational person, so I'm actually the furthest away from patients. So you'll see. As we all know, because of the awareness of long COVID, there is this increased recognition in the research community about post-acute infection syndromes. I think everybody on this conference, at this conference, probably are quite familiar with the perspective published in 2022, and the title was actually from a San Francisco Chronicle news article that says, along hidden disease, obviously, MCFS is pulled from the shadows by its cousin, long COVID. I think that's a nice title. And in addition, actually, the news article is talking about a patient who's unfortunately bedridden for more than a decade. I actually had the opportunity to know that patient before he was sick, and he was a brilliant young photographer. I still remember, how he was active before he was sick. So I guess some of the research goals that are discussed for the past 2 days include, we need a diagnostic test that's reliable, so we can use that to diagnose patients and use it to evaluate potentially the treatment effect of clinical trials. We need a clear disease mechanism. Either it is persistent viral infection, or it is antibodies, autoimmunity, or it is a metabolic problem, or it is neural inflammation. Based on the understanding of disease mechanisms, we probably can direct either the development of effective treatments or precision medicine based on the underlying problem of the patients. And as we have heard a number of times in the past couple of days, a number of teams are trying to work toward identifying effective treatments. I'll talk a little bit about it in the next few slides. So this is just one example, which is a coincidence, I think, because we had a couple of discussions about the reproducibility of the results. We looked at 20 mostly bedridden patients a few years ago, and looked at a number of omics plus lab test results and cognitive test results, et cetera, on these 20 patients, and compared those with the controls. And this is about the only sort of significant finding that we found, which was that, as shown here, the red is the red shows patients, the blue shows controls, and you can see that in the morning, the cortisol level in patients were significantly lower than the controls, and then as the day goes on, they tend to become equal. And coincidentally, when we look at, for example, the publication by Klein et al. Last year in long COVID patients, as you can see on your left side, the left panel, that's healthy controls, post-COVID patients without problem, and long COVID patients, the LC. And you can see that the cortisol level they measured between 10 a.m. to noon shows significant difference. And in fact, in that paper, they say that just by using that, you can distinguish patients from controls with an AUC of 96%. And just to bring your attention to another publication in 2022, where Mark Davis' lab looked at COVID patients and distinguished them based on post-COVID sequelae. And from the left to right, the red box plot shows people with high post-COVID problems, followed by the orange ones, and then by the blue ones, which show no problem after COVID, and the green box plot shows the healthy. So you can also see the lower morning cortisol in long COVID patients. Now, back to the point that I think a number of speakers have already raised, correlation has nothing to do often with causality. Is this just a reflection of the, for example, sleep problems in the patient? And if you actually treat it, whether that can help the patients or not. All those questions I think need to be studied. So in our lab, since we're computational biologists, the only thing that we are good at is to do computation. So from our perspective, the way to actually piece together how to lead to a better understanding on the disease mechanisms and the treatments in a complex disease such as ME/CFS and long COVID would be to look at least these 4 different types of data. One is the research data, the omics data that I think folks talked about at this conference. And then the second is literature findings. The third one is electronic health records. And the fourth one is patient surveys, because traditionally, at least in the US, one of the challenges in looking into the electronic health records is that ME patients were not that really well coded. And I know Dr. Systrom's group is trying to visit some of the electronic health records, and we're working together on that. And in particular, we'll focus on analyzing the immune systems, the metabolic systems, and I think the nervous system is really hard to study, and I hope that someday we can, have a better understanding of that. So I'll skip all the studies that we worked collaboratively with a number of people on this at this conference, Dr. Systrom, Dr. Burquest, and other folks on this at this conference. But instead, I'll just talk about something that might be a little bit more closer to patients. That is, we did a survey almost a year ago that was led by Masa Aki, who's a pharmacist and also a patient researcher. She envisioned and developed a survey questionnaire. I think some of the patients at this conference probably know about the questionnaire that essentially asked about not only patient symptoms and their comorbidities, but also asked the patients to self-report on the effect of over 150 treatments on their overall health conditions as well as individual symptoms. So it took her, I think, a tremendous amount of effort and determination to achieve this, and I can only show my highest respect to her dedication to this study. And Peng Li in my lab did the data analysis that I'm about to show you. So this is just a summary of the about 150 different treatments. The details can, I think, still be reached at the study page site that Linda talked about earlier today. So first, we looked at the patient age and gender distributions among roughly 2,000 ME/CFS patients and about equal number of long COVID patients. As you can see on the top panel, that's long COVID age distribution and ME/CFS age distribution. They look quite similar, and I think it's not a surprise to anybody that females represent 70 to 80% of the responders. And the bottom shows the distribution of gender, and probably it's not a surprise to this audience that patients start to get diagnosed with ME/CFS or long COVID, start from their 20 years old to 65 years old. So they're in the most productive time of their lives, unfortunately. We then looked at the disease duration, and because ME/CFS is a long-term chronic disease, so I guess it's as expected, a lot of patients, unfortunately, have already had more than 20 years of diagnosis of ME/CFS, and the bottom is long COVID, and as expected, the maximum would be somewhere around 3 years since 2020. So one thing that we noticed is that among the responders, most of them seem to start responding, when they're at least 6 months after they had the disease. So in other words, their symptoms didn't really resolve after at least 6 months, as you can see here in long COVID. So in a sense, their symptoms are persistent. So this is a comparison of the symptoms. So we basically ask them, what are the most bothering symptoms? Your left side in blue are ME/CFS patients. Your right side in red are the long COVID patients. So as you can see here, the top bothering symptoms are fatigue, PM, brain fog, refreshing sleep, memory problems. So these are, in essence, the symptoms that we know very, very well in the ME/CFS community. And perhaps the only sort of slight difference would be, you would potentially see there's little bit more shortness of breath on the long COVID side, and there's more chest pain on the long COVID side, which probably makes sense. This is probably the meat of the results. So what we did was that we used one treatment that doesn't likely impact patient symptoms, substantially, and also there are enough number of patients that took it as the control. So our reference, which is the second from the bottom, and use that as a ad hoc placebo, and then compared all the 150 other treatments to that one, and just in case other patients still want to take this survey, so I just didn't really spell out that particular control, and then we calculated what are the treatments that would show most statistically significant benefit. In other words, the number of patients or percentage of patients showing positive effect minus the percentage of patients that showed negative effect, and do a statistical test to see what are those that would be statistically significant. And we ranked it based on the statistical significance. A consideration here would be because of this type of analysis, it would bias toward those treatments that a lot of patients have responded. So that's the reason that if you look at the top, you get fluid intake, which is the top one, because out of the 4,000 also patients, at least 3,000 tried and responded. And the dark orange, medium orange, and the light yellow represent either the patient responded that their condition get helped much better by that particular treatment, or modestly better or slightly better. And on the right side in blue, you see the slightly worse, modestly worse, and much worse in the response. And what we can notice is that for example, fluid intake, you don't really get that many patients responding that there's a side effect apparently taking that treatment. The second one is pacing. So there, only 800 patients responded to pacing, but you can see that in terms of the percentage of patients that responded positively, there seems to be a little bit larger, positive effect. I think it's not a surprise to this group. Pacing is this idea of essentially keep within the envelope, as a number of speakers already discussed, in contrast with graded exercise therapy, which is bottom. So you can see for graded exercise therapy, almost like 80% of patients responded negatively, while pacing, the vast majority of patients responded positively. And that's followed by compression stockings, which is, I guess a treatment that's easy to try, and followed by the H1, H2 antihistamine inhibitors, where you also get something like 3,000 patients responded, and then followed by the nattokinase and the lumbrokinase. These are supplements that in the US one can get from Amazon. These are protein extracts from natto, which is fermented soybean, and lumbrokinase is an extract, if I remember correctly, from one of the insects. And their proposed mechanism is to digest microclouds. My understanding is the exact mechanism is not well characterized, but among the almost 1,000 patients responded, it seems like a significant percentage of them responded positively. And that followed by low-dose nitroxam, which has been discussed here, and beta blockers or ivabradine. In particular, ivabradine looked more positive than beta blockers for probably obvious reasons. And then you get melatonin and other selected MCATs. So these are sort of more specialized MCATs inhibitors, and then IVIG and B12, this lymphatic drainage, ADHD medication. So one can see, for example, here, for ADHD medications, for example, some of those neuropsychic related medications, you do get a significant percentage of patients responded positively. But then the negative percentage is also often larger than some of the other treatments. And that's the reason that its ranking is not as high as some of the other treatments. And then you get this anticoagulant, and this Maraviroc is a AIDS treatment, but it has potentially immune regulatory functions. And there's a small number of patients tried it, and apparently they seem to responded positively. Followed by mastinone and CoQ10, vagal nerve stimulation, PEA, which was talked about, I think, yesterday, and some of the probiotics. So on the right side, it shows that the effect of these treatments on individual symptoms. And as we can see here, very few treatments apparently treat all the symptoms. In fact, I think none of them apparently treat all the 5 symptoms according to the IOM criteria for ME/CFS. For example, the fluid seems to help mostly PODS, as you can see in the middle square on the top row. On the second row, pacing would help fatigue and PM and brain fog. And then, perhaps, as expected, you would get compression stocking, and you would get ivermectin and, mastinone, and also IVIG that seems to have effect on PODS according to the patients who responded. While you would get something like ADHD medications that seems to help mostly on the fatigue and brain fog, but not apparently helping, according to the patients who responded, PODS or PM. So, not being a physician, I think this is, perhaps as expected. Melatonin is apparently the only one that seemed to be reported to help sleep. So I'm going to show a little bit sort of the details. And this might be sort of controversial. I was discussing with some of the physicians. The reason is that whenever we have a survey, unavoidably, we would get some of the treatments, especially if they're supplements, that we don't really know what they do because they're supplements. But, just because it's a scientific meeting, and I think, if anybody see that there might be something here that might be useful, please do talk to the physicians and get medical advice from this. On the other side, if we only look at the side effects, these are the treatments among those 150 that showed the highest number of side effects, and perhaps, not unexpectedly, other than the graded exercise therapy, most of the rest are those ADHD or neuropsychic treatments. So, one of the things that we're still trying to figure out is, along the lines that a number of speakers already talked about, whether we can actually do a data-driven analysis to identify which subgroup of patients can benefit from this type of treatments and which might potentially be hurt by this type of treatments. One of the examples would be Abilify that shows it's more than 2 milligrams. So if you have a higher dose of Abilify than what the super low dose, you get significant percentage of people would not be able to tolerate it. Next, we did this comparison. So between the treatment effects of ME/CFS versus long COVID, which is on the y-axis. The line shown there is x equals to y. So the area of the circle shows the number of patients taking that treatment. So what you can immediately see here is that most of the treatment seems to be responded positively, more positively on the long COVID side. Obviously, one question would be, whether the ME patients, because they typically have longer duration and maybe they're sicker. That might be one reason. And another hypothesis could be that earlier treatment might hopefully help the patients. However, there are only 3 treatments that were not significant in ME/CFS, but significant in long COVID, and labeled those 3 treatments. So these are the ones that the ME/CFS patient did not respond significantly positively, but long COVID patients did. So as I mentioned a minute ago, we were trying to see, whether we can actually subcluster patients, since we have 4,000 patients, based on their symptoms and the comorbidity. And this is a presentation heat map of the 4 clusters that we identified. So from your left to right, your left one, you can see is mostly reddish color, meaning that the patients in that group 1 seem to have the highest percentage of symptoms. In contrast to number 4, which on your right side, rightmost one, that's mostly bluish, and that means that there's a subgroup of patients that seems to be not really having that high percentage of symptoms, especially if, for example, we look at POTS. There are very few single-digit patients in class 4 that has POTS. So POTS seems to be, in this case, most prevalent in class 1 and class 2, and very low in class 3 and 4. And each class actually has almost equal number of patients. However, class 3 has a higher, as you can see, red, of brain fog and unrefreshing sleep. So it seems like you either get a group of patients, unfortunately, they're having all the symptoms or most of the symptoms, and then there's 2 middle groups. One group has a lot of POTS patients, and the other group has a lot of brain fog and unrefreshing sleep. And then the last one seemed to be more modest in terms of severity. So we then asked the question, if we look at the efficacy of the treatments in each group, would some of the treatments might be different from each other? So as you can see on the right side, indeed, it seems like, for example, pacing seemed to be working across the board according to patients who responded. Similarly for fluids, and IVIG seems to work the best on those patients with POTS. Yeah, and and so on and so forth. For example, mestinon would work mostly on patients with POTS as well, and you get ADHD that seems to work best on patients that do not have POTS but have mainly brain fog and sleep problems. I think this is just preliminary analysis. More detailed work needs to be done, both on collecting patient input as well as, I think, a computational analysis. So I'll skip a lot of the things, but I just want to say the limitation of this is obvious. We definitely need to do randomized control trials eventually to prove some of these ideas that we talked about. And there are a number of issues that might affect the patient's response on the treatments. So I hope that a work like this, for example, in Portugal, maybe it could be something that can, at least in the short term, help patients deciding what to try, and at least talk to the primary care physicians, and eventually we hope that from this type of studies, as well as some of the other studies I'll conveniently skip for the next time, we can prioritize drug candidates for clinical trials. So this is sort of another talk that I'll just skip. But the idea is basically if we just aggregate, I think one of the speakers already mentioned, these days is sort of AI age, and you have large language models, etc. So what we did was we basically get all the findings that we can have our hands on, and essentially try to compare what we learned on ME/CFS and long COVID with all the other diseases out there. There are 30 million publications in PubMed, and you just ask, what would the ME/CFS on the right side, on the left side, which use coyote because it's a new world animal, and gray wolf on the right side, which is everywhere in the world. So suppose somebody go to America and find something that you don't understand, naturally we would try to see, if that, in this case, animal is similar to something that I know well. And then if I do identify gray wolf to be similar to coyote, then can we actually treat by borrowing strands from what we know? In other words, the diseases that we identified to be similar to ME/CFS and long COVID, and if a treatment is already effective there. So I'll just skip the rest and just want to thank my, this is a patient in my lab that he unfortunately had a post-COVID ME/CFS, and he would put this puzzle on our conference room desk, and would spend months trying to put it together. And I took a couple photos, and then he ended up having to leave the lab. So with that, I think it's just a mission for me to try to be helpful and work together with everybody on this at this conference, and hopefully we can solve this puzzle soon. And I actually at the end put the pieces together for him, and when he left the lab, he actually framed it, and is still hanging on our wall.